here's what we're going to talk to you about today. I'm going to start by giving you an overview of the linked data that exists in New Zealand. And I think this is an important place to start because New Zealand leads the world in linked data and it is underused. So I hope that I can spark some enthusiasm for you all to jump into some of the linked data that we've got and get some insights out of that because it's not used enough. I'm going to give you a real example of what linked data can tell us, and then Ernestynne is going to give you an example of some different analysis that we've done using operational data to automate decisions. Now, we've purposely chosen two very different types of analysis. The linked data that we have in New Zealand is all de-identified, and that means I can know that I've got individual level data, but I don't know that it's Kylie and Ernestynne and Andrew. I know that it's person 1, 2, 3, 4, 5, 6, 7, 8, 9. What that means is the insights that I can gain from it aren't about an individual person, but of groups of like people. And that can be really useful for understanding system-level insights to help with policy change. And Ernestynne is going to be talking about analysis done on operational data. So you do know that it's Kylie, and you know that it's Ernestynne, and you know that it's Andrew, and you can make individual decisions about individual people. Now, both those types of analysis are useful and valid, and we've purposely chosen them because they're quite different to give you an idea of the broad range of things that you can do with the amazing data that we have here in New Zealand. In New Zealand, we have something called the Integrated Data Infrastructure, and I'll refer to it as the IDI from here on out. It is a taonga, it's a treasure. What it is a database of linked data. So at last count, more than 60 different data sets at the individual level de-identified. So the types of data that sit in there across the health sector, everything from ACC claims, dispensed pharmaceuticals, lab tests, mental health and addiction services, maternity services, birth, death, marriage records, hospital admissions, ED, primary healthcare registration, so a whole vast range of information from the health sector, but also social development information, so welfare, justice, courts, corrections, police, education, primary, secondary, tertiary education, and that's just government. So there's also ACC in there, there's a range of NGO provided data, so primary healthcare organisations. There's also other organisations like Auckland City Mission, and then our National Statistics Office, StatsNZ, also have most of their social sector surveys in there as well. So things like the Household Labour Force Survey, economic surveys, surveys about the social well-being of people, and the census as well. And that is all linked at the individual level, available for research purposes, and all de-identified. And it's a time series, so the oldest record in there, I think, goes back to 1840, but most of the data sets in there sort of cover the last 10, 20, some of them 30 years. A whole wealth of information, and it is underused. So as I go through the next few slides, if it does spark an idea for you, please come and have a chat, because I do want more researchers to use this amazing resource that we have. It is all managed by StatsNZ, our National Statistics Office, and they have a very robust process for accessing it. Accessing it is based on a project-by-project, person-by-person basis, and they do a very good job of that because it's important to keep that information safe. So it's best described through examples, so I'll just get into those. What this plot shows you is on your left-hand side is New Zealand's social vote, which is the money that our government spent on our social services. And in 2013-14, that was about $53 billion. And you can see how that's broken up here. So social development, which is our welfare, was about 22 billion, health sector was about 14 billion, education 11 billion, and you can see how the rest is split up there. For everyone overseas, I guess the values aren't what's important, it's the proportional split. And if you look at social development there and think that that's quite a large proportion, it's because half of that, about $11 billion in that year, was spent on our superannuation, which I guess is a universal base income for everyone over 65, which our government pays. Now, using the IDI, you can attribute this money spent in services received to individuals. So does anyone want to take a guess at how much of the money that our government spends on social services for people you can attribute to a person? Give me a proportion. 40? A bit higher? A bit less. It's about 2/3. So about 2/3 of the money that our government spends on people is linked in this research database. That's quite a lot. And you'll see there that some organisations like welfare have a greater proportion that you can attribute to an individual. That's just because most of the services that they provide are financial, and there's regulation around financial information, and so you would expect the quality of that and the accessibility of that to be high, versus, say, the health sector, where the system is a lot more complicated in New Zealand. You've got DHBs and primary healthcare organisations providing services to people, and it's easy to say someone received a benefit for $400 a week, not as easy to say someone received a hip replacement, for example. So that kind of gives you an idea of the scale of the data that's captured. You'll also see there that some of the organisations like Justice and Police don't have any financial information attributed to individuals. There's still information about offending, victims, about sentencing and remand, but not all of those are costed. So there's still information about those experiences and services, but the cost information isn't there yet. Okay, another example. Was anyone here born in 1990 in New Zealand? Couple at the back. So you're turning 29 this year. So what I'm about to show you is everyone born in New Zealand in 1990. So in New Zealand there's about 65,000 live births every year, so it's their cohort. And what I've done is I've gone into the IDI and I've found them all, and then I've followed them from the 8 years since they finished high school up till 2015. So they went to high school. After high school, I followed them in the data, and I looked at what services they received and the cost of those services. So on the y-axis, what I've got here is the cost of those services in millions, and along the bottom I've got percentiles, so 100 percentiles, so that means in each group there's about 650 people. And all I've done is sort them by most expensive services received down to lowest. And I'll show you what that looks like. So as you would expect, the distribution of this it's skewed that way because, I mean, that's kind of the point of paying tax. The people who need services get them and not everybody does. But there's some interesting things to point out in this plot. The top 16% most expensive cost more than the rest of the country. And I'm not saying, I'll be very clear when I'm showing you, I'm not saying expensive as in we want to reduce that spend, because when people are entitled to services, we should make sure that they can access them. The reason that I'm showing you financial information is because just by its nature and the regulation that sits around it, the quality of it is high. Of course, we want to get to a place, I think, where we're actually measuring true well-being of a person. But I'm also I have a very strong opinion that just because the data that we have today is not perfect is not an excuse not to use it. I hear it all the time in my job that the data quality is not good enough, or we just need some more data. You can't tell me that we have this data sitting there linked at the individual level. You can't say that we don't have enough data. We do. My view is that we should be doing more analysis on it, and the value that's delivered by that analysis will drive the demand for more and better. So put that aside. Top 16% most expensive more than the rest of the country. The top 1% most expensive group, $160 million spent on them over the 8 years since leaving high school. And what's interesting about this group is that the majority of them did not achieve NCA level 2, which is a sort of standard high school qualification for us here in New Zealand. Now, this doesn't actually tell you what you can go and do, but I think what I'm trying to show you here is that the power of linked data, before data is linked, if you're sitting there with your health data set, you might think about health outcomes, and if you're sitting there with your education data set, you might think about it from an education perspective, and vice versa for all the rest of the departments in here. But what I'm hoping to show you is, if you knew, so we did know actually, 8 years ago, we knew the students who didn't achieve NCA 2. If I told you that there was a high probability that over the next 8 years we were going to spend $160 million on them as a group, which is about $250,000 each, my question is, what would you do differently? You know, $250,000, that can buy a house in some parts of New Zealand. You know, what I want people to start doing, not in Auckland, not in Auckland, what I want people to start thinking about is what does it look like when you put the person and the person's need, not the health needs, not the education needs, not any of the siloed hats that we usually wear on our day-to-day jobs. What does it look like when you put the person at the centre of your analysis and you can bring all this data together to understand their lived experiences in their life? What does it look like and how would you act differently? So, as I say, this is very high level. You can't just jump in and say, right, this is what we're going to change or do about this. And so I'm going to give you one more example using the IDI where I hope it is a bit clearer that you can do something. Oh, and I will also say yesterday that Andrew Spall showed his fancy division. This is a sum. You know, so when I say more people need to be using it, we don't really need statisticians. Like, that would be useful, but this is really, really simple stuff. And there aren't enough people that are taking that top-down sort of holistic person view using this data. So if that's where your skill set lies, then please come and have a chat. The example that I'm going to show you is social housing. And this is a health conference, so you're probably wondering why I've chosen that. But I'm sure you all know that without a stable, warm, dry place to live, we all know what happens to people's health. So I'm using this as an example because it's important for every aspect of a person's well-being. What we did in the IDI is we looked at everyone that applied for a social house in 2005-2006. And there were a group of people who were successful and they were given a social house, and there were a group of people who were not successful and they did not receive a social house. So we found them in the data and we matched them. So we said, in the data, we've got two groups of people, one who received a social house and one who look exactly the same across every data point that we could see, except the only difference is that they didn't receive a social house. And what we can say when we do that is a causal statement about the impact of social housing. For the data scientists in the room, we used a propensity-based approach, and the model that we used was a gradient boosted tree. For everyone else, just know that it's more complicated than a sum. Then, after they received a social house, we followed them in the data. Followed them in the data, that sounds quite creepy, but anyway, we watched what happened to their experience of the data 6 years after receiving a social house. And we followed them across corrections. CYF is Child, Youth and Family, so that's like our Child Care and Protection Youth Justice organisation, now called Oranga Tamariki. Education, Health, ACC, MSD is Social Development, so our welfare organisation, and IR is Inland Revenue, so that's our tax, we can see how much people earn. We followed them in the data, and the boxes there that are in orange are where we had significant results. So we'll see if you can figure out what happened to them. So you give someone a social house, what do you think happened to the corrections spending as a result of getting a social house? Does it go up or down? So put your hand up if you think the spending went up. Okay, for education, hand up if you think the spending went up. Few. About a quarter. Social development, benefits, do you think the spending went up? A few, handful, yeah. And inland revenue, do you think people earned more or less money? Hands up for more. So more people that time. Okay, here are the results. The spending on corrections went down, and that isn't because there were a reduced number of offences, it's that the seriousness of those offences was reduced. So people were in jail for less time, saved money. Education spending went up, in fact. Children stay in school longer. You know, now that I've said it, it probably makes a lot of sense. You give someone a warm, dry house to live in and you give them stability in their lives, and their children are able to go to school and stay in school for longer. Social development spending went up, and I interpret that as positive because when you give someone a stable place to live, they can access the services that they are entitled to. This isn't an exercise in figuring out where to save money, it's an exercise in figuring out how to best support people. And if that means supported payments and benefit, then great, it's good that that would go up then. People access better support, and they actually earn less money, and that's a direct impact of the policy setting. So in a social house in New Zealand, the rent that you pay is based on your income. So when you get to a certain point, dollar for dollar, there's no point earning it. And people are smart, they figure that out. You can see people in a social house get to a certain point and stop earning. And you can see there people earn less. So what did we do with this? The results of this analysis went into a joint budget bid with Housing New Zealand and Department of Corrections to prioritise prisoners coming out of jail into social housing to support them to live stable lives to reduce reoffending or the seriousness of that reoffending. One thing that we did. And you might be looking at this and saying, well, okay, where are the health results? And the reason that I haven't showed the health results on here is because as a whole, health is not significant. Not a significant result. And you would expect that because some health spending is, I guess, a positive or preventative thing. You might think about elective surgeries or immunisations, actually, as a positive preventative thing. You might think about emergency visits, or, I guess, a better example, treating a child for a rheumatic fever and then sending them home to a DAP house as a result of social housing is not a positive thing at all. So I will tell you that the two positive significant results from the health sector data were there were reduced claims in general medical subsidy. General medical subsidies are basically when you're not enrolled in a primary healthcare provider, you pay more for primary healthcare visits. So you should always enrol, and I guess when you give someone a stable place to live, there's increased enrolments in primary healthcare, which is a positive thing. Mental health service spending also was reduced, and again that probably makes sense because you're reducing a lot of the stress when you give someone a stable place to live. So that's an example of when you're bringing all this linked data together, you can really put a person at the centre and understand their experience across a range of domains around a person, not around a silo. And you don't need the data to be operational. You don't need the data to be at the individual level because this is enough. If you can't look at this and think of something to do, then you should think harder because it's quite self-explanatory. Anyway, I'm going to pass you over to Ernestynne now, who will talk about the operational data analysis. Ernestynne.
Thank you, Kylie. Kia ora koutou. Did you know that in the past, ACC would manually process over 2 million claims every single year? Nicholson Consulting and ACC formed a partnership to automate this process so that we get more consistent, faster, more accurate decisions in this area. In the past, clients would have to wait weeks to receive a letter in the mail saying that ACC would cover the costs of the treatment. That can be quite stressful if you've got a lot of bills and you're wondering, who's paying for my treatment? Thanks to a series of predictive models, we've gone from a situation where it takes weeks for that letter to a situation where you guys can hit submit on your practice management software and the client could receive a cover notification via text, and the best one we've seen is 7 seconds. 7 seconds. I led a team of data scientists that built all the predictive models to help with the automation. So what I want to do today is cover the business impetus. Why was it that we needed to come up with this automated solution? What were the challenges that ACC and its clients were experiencing? I'll talk briefly about the services, the predictive models that we created, and I'll also cover what were the benefits of these models. Finally, I'll wrap up with some key takeaways that we learned about this process. So first up, let's start with the business problem, because that's always where you want to start. Those 2 million claims, ACC had 60 staff dealing with them. They were doing a raft of things behind the scenes. They were looking at data quality. So do we have the right person? Do we have the right address to send out a letter? And so on. They had to make the actual cover decision, saying that ACC will cover the costs of the treatment. There is also a free text field on the claim form where you explain how you had the accident. Those staff members were converting that into structured data that could be used by other parts of the organisation, like injury prevention. And finally, they were having to stream the claim to the relevant team so that clients could get more support and the relevant access to services that they needed. So for instance, there's a sensitive claims unit that deals with the sexual assaults as an example. So you can see that there is a lot of manual processing going on behind the scenes. ACC asks clients for feedback about the process, and to sum it up, it's too complex, can't understand it, takes too much time, and ACC is reactive rather than proactive. A similar sentiment was shared by the providers, who said that it took a long time to fill out all the forms and that they found it was difficult to do business. So this was the impetus. This is what prompted ACC to create a client transformation program. This is going to revamp the experiences that the client has, that ACC's business customers who pay the levies have, the healthcare providers, you guys, everyone in Aotearoa. So those 2 million claims, 90% of them are considered straightforward, simple, obviously things that ACC is going to pay for, something like a cat scratch or a broken ankle. The 10% are the more complex claims, like the sensitive claims, or if you have an accident following a medical treatment. Those are the sorts of things that you still want staff members who have the expertise to deal with. But that 90%, there's an opportunity there for automation. So we help deliver 2 different services. We have a cover decision service that's now going to automate that decision making. And we also have an accident description service, which is going to take that free text field on the claim form and create the structured data so that other areas of the business and other organisations can use the structured data. So first up, we'll start with the cover decision service. This is looking for the simple claims that ACC can fast track. It's made up of 2 models. The first one is a probability of accept. Is this a simple, straightforward claim that ACC can fast track? So what comes out of that is a probability, and if that probability is above a threshold that ACC has set, then we say that is a simple claim and we're going to fast track it, so you could potentially get that text message. If the probability is not high enough, then a second model is used to help make the decision, and this is the complexity model. As the name suggests, it's looking at how complex a claim is. If you have a low complexity claim, what we tend to find is that it actually costs more to investigate what had happened than the actual cost of the treatment. So something like you've got a crayon stuck up your nose, once you take it out, what else is there? It costs more to investigate what's happened. So in that situation, there's little value to ACC, there's little value to the client, there's little value to the health provider to investigate these. So if it is a low complexity claim, and it's below a threshold, again set by ACC, then that claim can also be fast-tracked. So what do we have left? We've got the claims that have a very low probability of accept, and we also have the claims that kind of have a middle ground probability, but they have a high complexity. So these ones, they are sent to staff members who have the expertise to deal with them. So what are the benefits of a solution like this? Well, for one, a client could potentially receive their cover decision while they are with their health provider. This type of solution easily scales. If there's a large event like an earthquake and the claim volume suddenly increase, the system can deal with that. It also frees up staff from doing lots of manual data entry type tasks, so they can focus on more value add tasks for the clients. And finally, this solution is more transparent than before. Clients can actually log on to My ACC and access information relating to their claim. Even if you're not injured, you can still access information. The technical summary and some of the other documents were published on ACC's website before this went live. So you can actually look at what was the impetus for this change, how do these models work, including what variables are used in them. You can also look at the huge section that looked at ethics and biases as well. And there's a big write-up in terms of what tests did we do to check that these models weren't biased against particular groups. So all that is available on ACC's website. The next service is the accident description service. When there is an accident, you fill out on the form, how did the accident occur? And the staff members were populating 11 structured fields. So for instance, they were looking at what caused the accident. Did someone slip? Was there a shooting? Was there a fire or something else? Right through to other fields like, if this is a sporting injury, what type of sport is it? So how this works is, for the data scientists, there is a batch of logistic regression models. And if you're new to that space, it just means there's something that tells you yes or no. And what we do is we look at that free text field, and we're looking for keywords that indicate it is a particular cause or a particular sport, and so on. And once we find the one with the highest probability, we're going to assign that one to the structured text field. So what we find is it's very similar to the cover decision service. It's scalable. You can also free staff up to focus on the more value add activities. And the good thing about this is when a predictive model is categorizing things, it creates more consistency. So as an example, ACC gets claims for insect bites. And what we're finding in terms of the cause is some people would say this is struck by an animal. Other people were saying this is called a puncture. And then some people were just throwing it in the other category. So when you build predictive models, they'll put all the insect bites in one category. And that consistency makes it easier for other teams like injury prevention, WorkSafe, and other organisations to deal with and understand the data. So both of these services are things that could easily be transferred to other areas of healthcare. Do you have a large volume of manual tasks? There may be some automation like this would come in handy. So yesterday we saw quite a few sexy examples, I'll call them, from Eric and Leo about healthcare applications in AI. And I think this one is actually a hot little example in its own right. And the reason for that is that it's operational. This is not a piece of research. This is not something that needs approval from a board to go live. This is something that is living and out there right now. The good thing about this as well is it really sets the scenes for greater things to be achieved. I can't really think of anywhere else in government where you have an algorithm that is doing automated decision making without a human looking over every single decision. Sure, there are plenty of examples of risk scores that are given to people, and those people use them to help make the decisions. But how many situations do you know of where the algorithm is making the decisions for the straightforward claims? So this could really set the scene for other areas in government. In terms of the healthcare sector itself, it's really foundational. Now that we have an automated system, we can go on to achieve greater things. Imagine if there was an interactive cover decision service where you guys are filling out the form and then you get a message back saying, hey, this looks like a treatment injury. These are the types of things we will need to make the cover decision. Would that make your life easier, wondering instead, which forms do I need to fill out? Oh, I need to call ACC to figure out what's going on. If it was interactive, it might cut down on some of that. So to sum up the key takeaways for these predictive models that we think are quite useful, the models are only fast-tracking the simple claims. I think that's how we got around the whole idea of an algorithm's making the decisions, is dealing with the simple stuff. These services will never deny anyone cover. Only a staff member can do that, and they will communicate that accordingly. So don't build models that deny people services. You're going to have a real difficult time getting them over the line. The thresholds that we talked about, the probabilities and the lines where we decide whether or not we're going to fast track or not, those are all configurable. They're set by the business, so ACC has the flexibility to change them as needed. Finally, we opted for a simple solution that was easy to understand. The frontline staff spent a lot of time helping us improve the models and understand where we could do some extra things to help improve. The developers could also understand what was going on, which made it easier for them to implement. They were a bit worried. They thought, oh, we need data science skills, and we're not very good at that. And we told them, if you can add and multiply, then you should be fine. We even got to a point where we actually presented this to the executive, and they really liked the simple solution because they felt that they had a good grasp of what was going on in these predictive models. So that is how we went from going from a situation where you spend weeks receiving a cover letter to a situation where you can potentially get your cover decision in a few seconds with a text.